Hello friends, I am Dr. Ankit Madharia. Today I am going to show you a very interesting case of lumbar canal stenosis. This is a 60-year-old male patient who had complaints of back pain and right lower limb pain since 3 years. You can see I have taken a video of him. As soon as he started standing up, he developed claudication in his right lower limb and he was unable to walk due to this pain. Pain was basically in L4 and L5 distribution. Visual analog scale of the pain was 8 out of 10. Sensory, there was a continuous tingling and numbness sensation over the L4 and L5 dermatomal distribution. Claudication, as I mentioned, was just as he started to stand, he developed claudication. Power was grade 3 in the right side of EHL and EDL, and there was wasting of anterolateral compartment of his leg muscles. So this was his X-ray. On the X-ray you can see that he had developed a scoliosis towards the right side, and otherwise also there were a lot of degenerative changes in the X-ray, but his spine was quite stable, that there was no listhesis in this patient. Coming to the MRI, since he had a right-sided symptom only, I tried to diagnose his cause of pain, and I'm going to explain you how I read my MRI to find out what is the causative symptoms in this patient. Since on clinical examination his right side L4 and L5 nerve roots were involved, I'm going to trace those nerve roots back into the spine and I'm going to see where these nerves are getting compressed. So in this sagittal cuts, I'm going to just zoom in over here. You can see that this is the L4 L5 level, and you can see this is the L4 exiting root and it is getting compressed in this foramen. You can see other images. You can see this disc is bulging, which is compressing it against this pedicle, and there is ligamentum flavum over here. So the L4 nerve is getting compressed as it is exiting here. Also you can see that there is a bulging disc which is compressing the traversing root. We would see now. You can see over here that this traversing root is compressed by this bulging disc as well as ligamentum flavum hypertrophy from the back. So the L4 nerve root is getting compressed as it is exiting, and L5 is getting compressed as it is traversing this disc space. Coming to the L3-4 disc space, you can see the exiting root at L3-4 is quite normal. You can see this foramen is okay and there is no compression at the foramen, but at the traversing root level there is compression of L4 traversing root at this level. Now you may say that he has a multi-level disc at L1, L2, L3, L4 and S1, and he may need a multi-level decompression, but clinically I feel he has L4 and L5 only right-sided symptoms, so my targets are just those two nerve roots, and I'll try to decompress just those two nerve roots only. Comparing of the right side nerve root to the left side, we can see on the right side, this is the right side image. You can see this one is the right side image. You can see the exiting root L4 is quite compressed here, and if I compare the same exiting nerve on the left side, you can see it is how well open up this foramen is. So by these sagittal cuts, I have come to conclusion that only L4 and L5 nerve roots need to be decompressed, and I'll take you to the axial cuts. In the axial cuts over here you can see this is the L3 L4 level. Over here you can see there is a bulging disc, there's a lot of hypertrophied ligament over here, and right side there's a little bit of compression. So we'll just have to remove this bulging disc to decompress this area. So our traversing L4 nerve root over here would be decompressed by just removing that bulging disc. Coming to L4 L5 level, this is the upper part of L4 L5 level where you see there is the bulging disc. The foramen is closed here due to the bulging disc, and there is a lot of ligamentum hypertrophy over here. As we see at the disc level, this is at the disc level of L4-5 vertebra. We can see there is a ligamentum flavum hypertrophy as well as a bulging disc, and in the lateral recess there is a bulging disc which is compressing the L5 nerve root on the right side only. So I'll take you back to 3-valve 3-zone concept. Now 3-valve 3-zone concept is a newer concept which has been given by Dr. Satish Chandra Gore. Dr. Gore is an endoscopic spine surgeon from Pune, India. He is also my mentor, my guru, who has taught me transforaminal endoscopic spine surgery. And I like to explain what 3-valve 3-zone concept is. What Dr. Gore says is, in case of stenosis, there are very finite targets which needs to be addressed, which needs to be looked after, and if we address all those things, our surgical outcome are fairly better if we compare it by just opening and decompressing without looking at the targets. So I'll just briefly explain what the targets are. So Dr. Gore has divided the spine into 3 zones. Upper zone means the segment of spine that lies above the disc level, that is the exiting root area. The middle zone means the segment of spine which is at the disc level, and the lower zone means the segment that is below the disc level. So in the upper zone, target 0. 0 signifies that there is no disc in the upper zone. So there is no disc related changes. So there is no target regarding disc in the upper zone. There is ligamentum flavum hypertrophy at the tip of superior articular process that compresses the exiting nerve root. In our case, I'll just show you again. There is this ligamentum flavum hypertrophy in the upper zone, and there is some foraminal tissue over here which is causing compression of our exiting root L4 in L4-5 level. So our first target would be this ligamentum flavum hypertrophy. There is no pars defect in our case, so that will not be there. In case of middle zone, facet related changes, in our case, our facets have hypertrophied and their undersurface is covered by hypertrophied ligamentum flavum. So we need to address these issues. There's a bulging disc, so we'll address that. There's a foraminal soft tissue at G0. Now what is this G0? G0 is amalgamation of soft tissue at the junction of facet and upper level of the disc. So in our case, there is a foraminal G0 which is compressing the exiting nerve root. I'll just show you. So basically this tissue, the tissue which is lying under surface of superior articular process and the disc, so this forms an amalgamation and it leads to compression of the exiting root. So we will also be addressing this amalgamation of soft tissue, that is also called as G0. Next thing is in the lower zone. So we'll be addressing a ventral the structures which lies ventral to the traversing root. That is a disc bulge that is lying anterior to our dura. Dorsal to the dura, we do not have any structures in our case, and we do not have any synovial cysts. So in my surgery, my targets are already fixed now, so I have to address the ligamentum flavum in the upper zone, all 3 things in the middle zone, that is facet related changes, disc bulge and foraminal soft tissue at G0. And in the lower zone, I'll be addressing just structures that are ventral to traversing nerve. Now ventral to traversing nerve would be this disc bulge that you can see over here. I'll be addressing this disc bulge which lies behind the L5 vertebral body. So those will be my targets, and I'll show you how I'll address all those targets in a while. So I had taken the patient in the OT, I had given local anesthesia, and this was my line drawings and how I had planned. I had planned to do a transforaminal endoscopic decompression of L4, L5 and L3, L4 disc space. I would address all 3 zones in L4, L5 and just the middle zone in L3, L4. So due to the high iliac crest, my trajectory was going above the iliac crest and reaching just above the pedicle at L4, L5 level. At L3, L4 level, I had used the same incision, and I have drawn a line that was going above the pedicle. Due to the scoliosis, our line diagrams are not classical as described in textbooks, but this will work in our case. This is how I had inserted my needle. You can see this is not parallel to the disc space, but due to the high iliac crest, I had to come little bit oblique. I put my needle just at the posterior vertebral borderline and advanced it into the disc space. You can see it has gone just medial to the medial pedicle line of L5 vertebra. Over the needle I have changed it to guide wire, and over the guide wire I have inserted my dilator. You can see my dilator has entered the disc space and lying just below the annulus of L4-5 disc space, and in the AP view we can see the cannula is well advanced up to the midline. So this is a fairly good point to start my surgery, as most of the structures are lying epidural and I have to stay little flat in this case. So as soon as I enter the disc, I have landed just subannular, so I'll be working on creating some space for me to work over there. What you can see now is I am just removing some fragments of the disc. To orient you first, this is the L4 vertebral end plate, this is the L5 vertebral end plate, this is into the disc, and this side, the 12 o'clock or 11 o'clock, is the towards the epidural space, and this 5 to 6 o'clock is anteriorly or into the disc space. So we have gone from the right side at L4 L5 disc space and we have just started decompressing. Now I have increased the speed of video because the first part includes mainly removal and creation of space just subannular so that we could work there. As soon as I am done with removing those disc materials, I come out into the foramen and coagulate the structures. What you can see over here is the transverse fibers of the annulus. So this is the annulus and I'll start cutting the annulus. In case of bulging disc, we have to remove the annulus by just cutting it. Now this instrument that you are seeing here is my new favorite instrument. It's a bendable curette. It's very sharp and I use it to detach the annulus from the end plate. It is very atraumatic to neural structures, so I am not worried of damaging any neural structures. After detaching the annulus, I just shrink it so to visualize the disc structure. So this is our disc material that is bulging and compressing the thecal sac from anterior aspect. So we are looking at it from the side and we are using our annular cutter to cut it piecemeal and remove it with our annular cutter only. Now I use a plasma cautery to achieve my hemostasis and shrink the soft tissues. Now these disc material are just not loose and these needs to be cut always. In case of stenosis, there will be hard disc which needs to be cut by annular cutters and subsequently removed by graspers. As you can see this neural structure has started to appear and it has started to move freely now. So this is the dura which has started to move freely now, and I am working on the anterior surface of the dura. Now I always perform these surgeries under local anesthesia so that doing it under local anesthesia makes it very safe and also reduces the cost of hospitalization and the post-operative period. The patients are very pain-free due to this procedure. Now this is the same articulated curette that I am using to detach the upper end plate from the annulus. Now this is a tooth grasper that will just break up the redundant part of annulus and the nuclear material, and we have almost done our decompression till the midline over here, but we'll remove some more disc material. As we coagulate, these structures shrink and we could visualize it much better. I hope you can appreciate that this is the dura which is lying freely. This is a flexible annular cutter which can reach beyond the straight line. It can go in curved direction, and it can reach to the almost to the opposite side and cut the annulus. It's a must. It's an instrument which every endoscopic spine surgeon must have in his armamentarium, and it's a very useful tool. You can see how beautifully this flexible annular cutter is cutting the under surface and removing the bulging disc. So what we are seeing right now is this is the L5 nerve root, and we are first decompressing the L5 nerve root. So this is the middle zone that we have decompressed at the disc level. This is a flexible grasper that again bends and goes to the opposite side. So our nerve root over here is fairly decompressed. In the lower zone also I have removed the disc material. So the lower zone and the middle zone part is anterior part is done. On the middle zone there will be some facetal work that I'll have to do. Now after completing that, I am withdrawing my cannula to see the foramen, and as you can see the structures here, this is the structure that we call as a foraminal G knot. So you can see the superior articular process here and the disc material from here. Now these structures are compressing the exiting nerve root lying at the 1 o'clock position. So I'll just begin by coagulating any blood vessel over here, and I'll use an annular cutter to create plane anteriorly for me to work here. So I am removing those bulging disc material from here which were compressing my exiting nerve root at the axilla. Now you can see this is the exiting nerve root, and this is the dorsal root ganglia, and we are working very close to the dorsal root ganglia, so we must be very careful when we are using our cautery, because stimulating a ganglion can result in very bad post-operative dysesthesia. So I'm just using a curette to create a plane between the exiting nerve root and the dorsal root ganglia and the superior articular process. So you can see this is the exiting nerve root over here, and I have detached that ligamentum flavum which was causing compression at the axilla of the exiting nerve root. So this is the foraminal G knot, the tissue that lies that is amalgamation of disc and the tissue at the SAP. So this needs to be relieved also. So in the middle zone, this is the foraminal G knot that I was talking about, and I'll remove it by annular cutter and graspers now. You can see after removing this G knot tissue, our traversing root L5 is getting visualized much better now, and we can see the entire length of this L5 nerve root. You can see from the lower pedicle to the upper pedicle, the complete decompression of L5 nerve root we can see. We'll do further more cleaning, but this is the starting of the middle zone. This is the starting where we have decompressed adequately our traversing L5 nerve root. You can see some more tissue is left, which we'll subsequently remove now. This one. So this is the traversing L5 nerve root, and always I try to achieve hemostasis before proceeding ahead. So you can see this is very well decompressed. The disc level, the traversing root is very well decompressed. Just some tissues are being removed by flexible annular cutter. How beautifully you can see now the traversing route freely moving now, all done under local anesthesia. You can see this is the L5 traversing route with the dura material, and it has been adequately decompressed now. You can see all free now. Just some osteophytes at the upper end plate are being removed. So as we look at the foramen now, this is the exiting nerve root with the dorsal root ganglia, and we are creating a plane between the dorsal root ganglia and this foraminal ligamentum flavum. This is the upper zone decompression that I was talking about. The foraminal ligamentum flavum is the major cause of failed back surgery in open surgeries, because this is the area which is called as hidden zone of McNabb, and without removing the facets you cannot see this area. So most cases of failed back surgeries are the cases where there is a compression in this region. So after removing or detaching that ligamentum flavum, I would achieve hemostasis, and my traversing route is very well decompressed. You can see over here, this is the exiting route, very well decompressed. This is the dorsal root ganglia also, where you can see the axilla is very well decompressed. On the superior surface of the exiting route, there is some ligamentum flavum which I will decompress now. Now in case of transforaminal surgery, if we go by the 3-valve 3-zone concept, you must remember that stenosis surgery is a surgery where we need to create channel for the blood vessel to grow, or the venous congestion to get decongested. Now these venous congestions do not need lot of space. Just a 2 mm of extra space is more than enough for the symptoms of stenosis to disappear. You can imagine all those elderly patients of stenosis who have almost their spine are fixed, and when they bend forward they create almost 1 or 2 mm of extra space, and that relieves their stenosis. So what we are trying to do is duplicate that same phenomena. You can see at the end of the surgery now, the L5 nerve root is completely free. I do not remove this part of ligamentum flavum as it's not compressing the nerve root. You can see this is the L5 nerve root, this is the axilla, and this is the L4 exiting nerve root with its ganglia, and the axilla is completely free now. So this is a 3-valve 3-zone concept in which I have decompressed the L4-5 disc space. Now going to the L3-4 level, we know that this is just a disc pathology at this level, which is a bulging disc compressing the L5 exiting root. So I'll just insert my needle just at the mid pedicle line, and over the needle I'll change to guide wire, and over the guide wire I insert my dilator from the same skin entry. The dilator sits just subannular at that level. You can see in the lateral view it is just subannular. In the AP view the cannula is going up to the midline, and in the lateral view the cannula is half in and half out. Now I have purposefully placed my cannula such superficial in this case because I do not want to disturb this disc. It is only this amount of bulging disc which is causing the pathology. So I have just put my cannulas just underneath the annulus, and as I go in I would just be seeing the dura would be lying anterior to my working space. So in this cases I like to turn my cannula towards anterior side, so the mouth opening is towards the disc space and the bevel is preventing the nerve root from my grasper as I enter. So you can see I have started grasping with my but my grasper is towards myself. So this means I am working anteriorly into the disc space and not going epidural, and my cannula is preventing the traversing nerve roots from being caught up in this by my graspers. As I create some plane in the disc space, I will turn my cannula towards anterior space. So this is the disc material, bulging disc, which has come out at the start of surgery. Now I turn my cannula anterior, and now suddenly you can see this is the traversing nerve root, very well decompressed in just beginning of the surgery itself. This is the L4 nerve root. Again we are doing the same surgery from the right side. So this is the foot end of the patient, this is head end of the patient, this is anterior, and this is towards the roof. I use my articulating curette to detach those annulus from the lower end plate, so that makes our job easy. And you can see how well this L4 traversing route has been decompressed now. You can see how beautifully this L4 nerve root looks. I use a radio frequency to coagulate these open parts, and you can see how beautifully now, within 2 to 3 minutes of starting the surgery, my L4 nerve root is very well decompressed at L3-4 level. I used annular cutter to remove that redundant part of annulus, although it was not compressing, but I wanted to see the opposite side traversing route also, so I did this annulotomy till the opposite side, and you can see how beautifully it is decompressed, and it does not take a lot of time. The other next step that you are seeing now is showing that I'm just working on the edge to remove all the osteophytes, and I am also exploring the exiting L3 nerve, but all those things are free, so I did not need to do much of my job over there. So this is just removing the osteophyte at the lower and the upper end plate, so that there is no further chances of compression. And I'm using just my annular cutter to remove those osteophytes. You can see, although it has been decompressed well, but I like to remove those osteophytes as well. So you can see now, after removing all the osteophytes, how beautifully this disc space has been decompressed. You can see L4 traversing route with the dura. This is the upper zone, this is the lower zone, this is the middle zone. I have decompressed it all 3 zones, and that's it. That's the end of the surgery for this patient. So in the post-operative period, I advised patient to rest for 24 hours, and after 24 hours, this was his patient's video. He has started walking, his pain has reduced to 2 out of 10, and claudication was absent, and this was a very dramatic result that we see in lumbar canal stenosis being treated by transforaminal endoscopic surgery. This incision is only a 1 centimeter long incision, a single incision for decompression of 2 levels, and done under local anesthesia. Many surgeons feel that this case needs fixation, fusion and deformity correction, but this surgery is a very good example to show you that not all patients need fixation, fusion, decompression. They just mostly need decompression, and 90% of our work lies in identifying the cause of pain, the cause of claudication. And I believe that 3-wall, 3-zone concept by Dr. Satish Chandra Gore has been a breakthrough work in understanding the targets of claudication in lumbar canal stenosis. Thank you so much. Thank you for watching. I hope you liked my work. I am Dr. Ankit Madharia. I am an orthopedic and endoscopic spine surgeon from Raipur, Chhattisgarh, which is central part of India. Do let me know how you, if you are a spine surgeon, so how would you have done this case, and do let me know if you have any doubts. And thank you for watching. I'll see you in my next video. Bye.